Stanford Conversations in Menopause and Healthy Aging, the podcast, a trusted science-backed resource in menopause and healthy aging. When it comes to your medical and health education, tune in and submit your questions to world-class leaders in medicine and research. Stay informed, stay empowered, because your health matters.
Hey there, and welcome back to Stanford Conversations in Menopause and Healthy Aging, the podcast about living well through perimenopause, menopause, and beyond. I'm Dr. Karen Adams, your host. I am a board-certified lifestyle medicine physician and OBGYN, and I'm the director of the Stanford program in Menopause and Healthy Aging. We're back with part 3 of our 3-part series on the menopause journey, what you can expect when you go through perimenopause and menopause. My guest for this series is Dr. Sharon Hung. Sharon is an assistant clinical professor of internal medicine and is the director of women's health in primary care and population health at Stanford Healthcare. Dr. Hung and I see patients in our clinics at Stanford, but we're also teachers, and we're both very excited when we get to teach. And in this series, we're teaching you, the people who are going through it. Today, in part 3, we are discussing the Women's Health Initiative and other important studies and why they are important, especially the WHI, even 20 years later. Welcome back, Dr. Hung. Such a delight to have you.
Thank you for having me, Dr. Adams. I'm excited for our conversation today. So to start with, I want to talk about how we think about the safety of hormone therapy. 20 years ago now, the Women's Health Initiative, as you mentioned, had found, and it was widely publicized, that hormone therapy increased cardiovascular disease and breast cancer, and this significantly decreased the use of hormone therapy in menopausal women. Now we're starting to see an uptick in its use, but still only about 4% of women who could be on hormone therapy are actually on it. Could you talk about the findings from the WHI study?
Right. Isn't that remarkable that only 4% of candidates are on it? Boy, I feel like I'm seeing all of them. I know you are too. I feel like the floodgates have opened, which is such a good thing that people are seeking out healthcare in this stage of life. But the Women's Health Initiative really did inform our conversations around this. It still does, but it certainly informed our conversations back when the data was released. The interesting thing and things to know about the Women's Health Initiative is it was a huge study. It had 164,000 women in it. It was huge. The average age of the women in that study was 63. And if people were having symptoms, they couldn't be in the trial. So these were people who had already gone through menopause. They were, well beyond their final menstrual period. And the whole point of the study was to see if putting women on hormones improved cardiovascular outcomes. And so what they did is they enrolled women between the ages of 50 and 79 on hormones. So they were starting women in their 70s on hormones who had never been on hormones before, really being quite optimistic and thinking this is going to be great because of all kinds of observational trials we'd had before that, making us think that it was going to be a really good thing. And that was the whole point of the study. It was not designed to look at benefits. It wasn't designed to look at symptom management. In fact, symptom management was not included in the assessment. And if someone was symptomatic, they couldn't be in the trial because they would know if they were in the placebo group or got hormones, because if they got hormones, their symptoms would go away. And so that was how it was designed. It was never designed to look at the benefits of hormones in young women, in women at age 45 or 50. And so, unfortunately, for 15 years or so, everyone got very scared about hormones and said, oh my goodness, we really shouldn't be putting people on hormones, because the study was stopped early because it had reached predetermined cut points for heart attack, stroke, and breast cancer. And that's what hit the New York Times that morning. That's what hit Good Morning America. That's what made the phone ring off the wall in my clinic that day, is there was an increase in heart attack, in stroke, in coronary heart disease, and breast cancer. And so for 15 years, people didn't get hormones and people weren't trained to provide hormones to patients. And now the pendulum has swung back because we have 20-year follow-up data and we know a lot more now. But that's the background that I think often gets lost in the conversation. So I appreciate having a chance to explain that.
Yeah, that's so important to keep in mind the background and who was enrolled. That was very informative, Dr. Adams, because a lot of times people just read the New York Times takeaway and that really doesn't explain the whole story.
Exactly.
And so let's jump into breast cancer risk then. How should we talk about breast cancer risk with estrogen and progesterone hormone therapy to the average risk patient? Let's say they don't have any significant family history.
Right. People are very afraid of breast cancer, and rightly so. I mean, it's a terrible thing, and we don't want anyone to have to deal with that. But what women typically die of in this country is heart disease. So we have a conversation about heart disease risk and breast cancer risk, but breast cancer in particular is the thing that scares women, because when we're dying of heart disease, it's when we're in our 80s and 90s. When people are dealing with breast cancer, it's often in their 40s and 50s. So many of my patients know someone who's got breast cancer, or, they have friends or family dealing with it, and it is rightly concerning to them. So it can be very reassuring to hear that even in the worst case scenario with the Women's Health Initiative, that increased risk of breast cancer was very, very small. It was only 8 extra cases per 10,000 women in the group that was on estrogen and progestin. So let me say that again. 8 extra cases per 10,000 women per year. You think about 10,000 women, that's like half a football stadium, right? That's a lot of people. 8 extra cases, that's not very much. The risk is greater with a sedentary lifestyle, if you don't exercise, or alcohol intake more than 7 drinks a week, so more than 1 glass of wine a night, increases your risk of breast cancer more than hormone therapy does. And obesity increases the risk of breast cancer by 9-fold. Mm-hmm. So we think about hormones as this big risk when there's so many other things in our lives that bring more of a risk for breast cancer than hormones. Having said all that as well, the other thing that's important is that the hormones that were studied in the Women's Health Initiative were synthetic. They were synthetic oral estrogen and synthetic oral progesterone, and we don't use those anymore. In general, we use bioidentical transdermal forms that are much less inflammatory. The ones that were studied were very pro-inflammatory, and so we think that that's a worst case scenario, that 8 per 10,000 women, and that probably with what we're doing now, the risk is quite a bit less. So in a low risk person, someone who doesn't have any unusual risk for breast cancer, hormone therapy in general is going to bring with it a very minuscule increased risk of breast cancer relative to other things that increase that risk. And most people are so happy to be on it because they feel better, and you get some long-term health benefits for bone and heart, that they're willing to accept a very, very tiny blip in that risk. Again, about 8 extra cases per 10,000 women, worst case scenario.
Yeah, so important to emphasize that increased alcohol use, obesity, are bigger risk factors than hormone therapy.
Exactly. There's so much we have control over, and keeping it in perspective in that way. The other thing too to think about, to factor in, is the risk of not treating. If you are symptomatic, what's that going to do to your quality of life? How is that going to impact your sleep? How's that going to impact your mood? And then what are your bones going to look like 15 years from now? So there's also that the risk of not treating to factor into when we're deciding risk and benefits.
Right. And in the first episode, you mentioned this could last 7 to 10 years.
Oh, absolutely. Absolutely. And we'll talk a lot more about the particular symptoms and how they may relate to long-term health risks and benefits. There's a lot to unpack when we're talking about pros and cons of hormone therapy.
Right. And then, so what if someone mentions that they do have a family history of breast cancer, but no personal history? Does that change your assessment of the risks and benefits of hormone therapy?
Right. That's a really common question. I'm sure you get this all the time too. A family history is never a contraindication to being on hormones. So family history of any type does not make us say, oh, you shouldn't be on hormones. Now, depending on who in the family and at what age and, gene presence or absence of a BRCA gene, that sort of thing, we factor that into someone's risk. But if someone's grandmother had breast cancer when she was 80, that certainly doesn't concern me in terms of starting someone on hormone therapy. The type of family history that I do pay attention to is if someone has a first-degree relative, meaning a mother, a daughter, or a sister, who was diagnosed with breast cancer under age 50. That increases their risk. Or two second-degree relatives, two grandmothers, two aunts, two cousins, diagnosed under age 50. With that kind of a family history, I send people for genetic testing because they run the risk of having some kind of a breast cancer gene. Even though if they have a BRCA gene, it is we feel very confident that adding hormone therapy to that person's regimen does not increase their risk of breast cancer above and beyond the background risk that they have from that gene. So even if someone is BRCA positive, we still can offer hormone therapy in select situations. So family history and even the presence of a gene I think often make people shy away from being on hormones unnecessarily, because we certainly can consider it in those situations.
Right. And they are often the ones that are suffering a lot based on, some of the surgeries or anti-hormone therapies that they might have received.
Exactly, if they're BRCA positive. And,
Mhm.
then we always think about someone's breast cancer risk when we're talking with them. So average breast cancer risk for an American woman is about 1 in 8 lifetime risk, and that's about 12%. But that's not 1 in 8 40-year-olds. That's 1 in 8 90-year-olds have had breast cancer. High risk is considered if you have a risk of about 1 in 5, which is about 20%. So if someone has a 20% or more lifetime risk of breast cancer, we consider that to be high risk. And we figure that out on the basis of some of the calculation tools that we use to figure out high risk.
Yeah. And as we explained in the second episode, women with hysterectomy can be on estrogen only or so-called unopposed estrogen. It seems like a finding from the WHS study that was kind of lost in the mix was that patients who were in the estrogen only arm actually had a reduction in breast cancer cases compared to women who were not on any hormones at all. Can you talk a little bit more about that?
Absolutely. Such an important thing. And, when people are on estrogen alone because they've had a hysterectomy, the risk benefit profile really shifts. And those people had lower rates of breast cancer than the people on placebo. So it seemed like it was protective. So there's something about that combination of the estrogen and the oral estrogen and oral progesterone that seems to bump the risk. But when people have had a hysterectomy, you're basically golden. Everything is neutral or beneficial when we look at all of the outcomes. And so that's why we're so enthusiastic about IUDs for women who have a uterus, because we think it mimics that effect of the unopposed estrogen, because you're not taking the systemic progesterone. And most of my colleagues who are gynecologists who have a uterus have an IUD and a patch because we think it mimics the estrogen-only group. So when someone is worried about breast cancer risk and they've had a hysterectomy, I can be 1,000% reassuring to them and say, not only is it not going to increase your risk, it probably will be protective for you.
Yeah, I learned that from you, and it's been just so empowering to be able to tell patients that.
It's so great. I wish everybody could have a hysterectomy. Or an IUD. Hysterectomy or IUD for everyone.
And then turning our attention to cardiovascular disease risk, I think there was and still is a lot of concern that hormone therapy increases cardiovascular risk. However, when we look at the data stratifying women into different age groups, it seems like there's actually cardiovascular benefit in starting younger women on hormone therapy. I'm curious, based on recent data, do you think there's a role in hormone therapy in reducing cardiovascular risk in women less than 60?
Yes, and that is another super important message. Remember, in the Women's Health Initiative, they enrolled women between the ages of 50 and 79. And then they lumped all of that data together and looking at the rates of heart attack, stroke, breast cancer, etc. But when you parse the data and you divide it into decades, so women under 60, women under 70, women under 80, it was those women between 70 and 79 that had all the bad outcomes. And the women under age 60 behaved very differently on hormones than the women over age 60. And we have additional data on that from the ELITE trial, which was published, I think, in 2016 by Howard Hodis and his group at USC, where they put people on hormones. This was estradiol this time, and it was divided up by people under age 60 and people over age 60. And those women who started hormones under age 60 had slowing of the deposition of calcium into the coronary arteries in their heart. We are all depositing calcium in the coronary arteries in our hearts. That's just happening to everybody. But that process slows down in younger women who take hormones, women under 60. The women over 60 didn't have any negative outcomes. They just didn't get the benefit. We didn't see any slowing of the deposition of the calcium in the heart in those older women over age 60 that we did see in the younger women. So that has led us, that and the way the Women's Health Initiative data happened, which showed us that those younger women didn't have all those bad outcomes. That has led us to think about this in terms of a window of opportunity. There's a window of opportunity to start hormones, and it's when people are under age 60 or less than 10 years out from that last menstrual period. So if your last period was age 55, you actually have till age 65 to start hormones and be still in that window of opportunity. Really, really important and such a great opportunity for folks who are in that window of time where we can start it.
Great. And there's so much concern in women about the risks of hormone therapy, which we've touched upon. Can you remind us of other benefits of hormone therapy for long-term health?
Right. Not only symptoms, of course. I mean, I can take someone's hot flushes away in about 3 or 4 weeks by starting hormones, and people sleep better and their mood's better and all of that. So the symptoms are profound in terms of feeling better. But also, 15 years from now, people have better bones if they start hormones. They have fewer bone fractures, better bone density. You get a bump of bone density equivalent to osteoporosis drugs with estrogen. So starting people on hormones and keeping them on it is very bone protective and decreases fracture rates, hip fracture rates. It also decreases the rates of colorectal cancer. So people had fewer colon cancer cases in the trials when people were on hormones. So there seems to be a real association with brain health as well. So it's symptom management, bone health, decrease in some cancer rates, and cardiac and brain benefits. So that to me sounds like something I would want to sign up for.
Are there some women who you would not recommend that they take hormone therapy because the risks really might outweigh the benefits?
Mhm. Even in the people under age 60 who are in that window of time, there are some people that we typically steer them away from hormones, and that is anybody who has an estrogen dependent type of cancer. So breast cancer is the big one we think of, high grade or stage endometrial cancers, not the really low grade ones, but the ones where maybe they've metastasized. Those are the two big estrogen sensitive kinds of cancers that we generally steer people away. That conversation's getting more nuanced, in terms of the different subtypes of breast cancer or subtypes of endometrial. But again, in general, no breast cancer, no endometrial cancer. Anybody who's had a heart attack or a stroke, who's had a true cardiac event, we generally steer people away from hormones. People who have had a blood clot in their leg or their lung or their brain, again, with some nuance there, depending on the circumstances of the clot and the type of hormone we're using. And then anyone with undiagnosed vaginal bleeding, we want to get that sorted out first. Pregnancy, anybody who's pregnant, we wouldn't do hormone therapy for. And then people with active liver or gallbladder disease, because hormone therapy can make that worse. And again, with some nuances depending on the type.
And then you talked about how hormone therapy can take hot flashes away within a few weeks, and then also the benefit on some cognitive changes. Is there benefit for other symptoms of menopause? For example, I talk to perimenopausal women almost every day about weight gain during this time. Can hormone therapy make a difference?
Weight gain. Oh, yeah, we're going to have a lot to talk about that one. When people go through menopause, they eat the same, they exercise the same, they gain weight, and it settles right around their waist. And that happens for a couple of reasons. One is that we tend to shift our lean body mass more toward fat, that our muscles begin to get marbled with fat, and so we lose our lean body mass. And fat is much less metabolically active than muscle. And so two people at the same weight, one who's more fat is going to be burning fewer calories. The person who's more muscle at the same weight will burn more calories in their daily life. So that happens. Estrogen mitigates that a little bit. It has small but measurable impact on lean body mass. It will shift you a little bit more back toward muscle.
Can be really reassuring.
Mm-hmm.
And I've never been a good sleeper, so I'm curious, does hormone therapy help with insomnia?
Absolutely. It absolutely does. It cures night sweats, and the progesterone pill, if you're taking that form, hits the sleep centers of the brain. And so there are very clear data that show that hormone therapy is excellent for sleep disturbance.
And I can't tell you how many of my patients notice things like mood fluctuations, irritability, worsening anxiety, even before any cycle changes or even hot flashes. Can hormone therapy help with the mood lability that occurs during the perimenopausal time?
Particularly in perimenopause, this whole PMI thing, perimenopausal mood instability, is a real thing, and no one's ever heard of it, right? I mean, we all know what PMS is. We talk about it, we know how to treat it, and it's common parlance. We talk about it. PMI, no one's ever heard of, and it's more common than PMS. It's perimenopausal mood instability, and hormone therapy helps with that, whether it's a birth control pill or whether it's a patch and a progesterone pill. In general, it's very mood stabilizing, and people feel much more like themselves again.
And then I also hear patients complain a lot about their, ability to concentrate is deteriorating, their memory seems impaired, they're forgetting some things, they can't multitask as easily as they did before.
Right.
Can hormone therapy help with, brain fog?
What was the question? No, I'm just kidding. I'm just kidding. But right. I mean, that's what happens, right? Is is people are at the top of their game. They are running meetings. They're multitasking with their aging parents and their teenagers, and they just have to be firing on all cylinders, and they're not. It's driving them crazy. They're like, that project we did last week, what's the name of it again? Or even something as simple as, that guy in that movie, is so annoying. You can't get your finger on what you're trying to say. That is a perimenopause menopause symptom. That's a real thing. It's not early cognitive impairment. It doesn't mean that you're going to be demented in 5 years. Although if you can't remember the name of the street you live on, or you can't remember your child's name, then you need to get that evaluated. That is early cognitive impairment and needs to get sorted out. But just that I came into this room, I don't know why I came in here, or, where are my keys? I put them down, I can't find them. That is perimenopause. And there tends to be a real correlation between the severity of hot flushes and the severity of the cognitive symptoms and the improvement when we get the hot flushes under control. So treating that with hormone therapy can be very, very effective and helpful. We think of this as kind of a Venn diagram of sort of sleep and mood and cognition. And all of them kind of overlap, because if someone's not sleeping well, their mood tanks and they just aren't as sharp, during the day. So all of these things kind of interact, and hormone therapy can be beneficial for all of it.
Yeah, I'm glad you mentioned those examples because my house isn't very big and I do often forget why I went to the other side. So important to ask for examples to see if there's anything concerning, but glad that we can reassure most of our perimenopausal patients that is normal.
Exactly. So important. Mm-hmm.
And what about all the joint pains and discomfort that women can experience in menopause? Does that respond to hormone therapy?
It absolutely does. Joint pain is common. It's a common manifestation, frozen shoulder, or, just kind of general body aches and pains that tend to really improve when people are on hormones. And if they don't, then we start looking for autoimmune causes. Maybe they're developing rheumatoid arthritis or something along those lines. But musculoskeletal syndrome of menopause is a real thing, and things improve really quite dramatically and rapidly when we start hormone therapy.
And let's wrap up by clarifying the window of opportunity that you mentioned earlier. Women should be starting therapy before the age of 60 or within 10 years of the last menstrual period, but that doesn't necessarily mean that they have to stop when they turn 60. Is that correct?
Absolutely. We think when you start in the window of opportunity and just stay on it, that's very different from initiating it, starting it at age 70 or something. So there's no age at which we automatically stop hormone therapy. And I'll just say I am 66 years old, and they will get my hormone therapy when they pry it from my cold, dead hands, because I am not giving it up. I was fortunate enough to start at the right time, and the data is very reassuring to me. In fact, we had a really wonderful paper published a year or so ago in the journal Menopause, looking at people who started and stayed on it. And that estrogen only group, they had benefits or neutral outcomes in all of the different areas that they looked at. So if you're taking transdermal estradiol alone because you've had a hysterectomy, you had longer life. People died less frequently of all causes. So all cause mortality was diminished. And then in the group with estrogen plus progesterone, it didn't negatively impact people's lifespan. And so in the 20 years since the Women's Health Initiative, there have been no increased deaths from breast cancer, no increased deaths from cardiovascular disease, and decreased all-cause mortality, meaning people die less frequently of all causes when they're on hormones. So I have no problem keeping someone on hormones. In fact, I want to see them once a year, make sure that there's no new health history that I need to tweak the hormones or change something. But assuming that they're doing well, I just keep them on it. And there's no age that we automatically stop.
Thank you for sharing both your personal experience. I think that's really reassuring for everyone to hear, but also all the details about the science that backs up your own decision.
Right, exactly. And, Dr. Hung, we have covered a lot in this series, and I really hope that it helps women understand the journey. It's a process, right? And what works for you this year may not work for you next year. And it's so important to partner together with a good provider who can walk through this with you. And so I hope that this helps our patients to know more about what's real and what's kind of hype, and, because it can be hard to know what the best thing to do is.
Absolutely. Yeah, I've still had colleagues who tell me that their provider won't prescribe them MHT, even if they don't have any major contraindications. So I think this is great that we are empowering patients so that they can advocate for themselves with science-backed information that we're learning from you.
Right, absolutely. And you should not have TikTok be your medical team. So that we are here to provide you evidence-based, research-backed information. And Dr. Hung and myself and all of our colleagues at Stanford are passionate about doing our best to get through the noise and give women the evidence-based information that they deserve. So thank you, Dr. Hung, so very much for being here with me. And thank you to our listeners for joining us here on the Stanford Conversations in Menopause and Healthy Aging podcast. And we'll see you next time. Take care.
If you've enjoyed this episode of Stanford Conversations in Menopause and Healthy Aging, please take a moment to follow or subscribe to our podcast on your favorite platform and consider leaving us a rating or review. It's a simple, zero-cost way to support our work and help others discover the show. You can also stay connected with us on Instagram, YouTube, and other social media at Stanford Menopause. For additional resources, event notifications, and other updates, be sure to visit our website, menopause.stanford.edu, where you can also sign up for our program newsletter. Thank you for joining us, and most importantly, thank you for your interest in advancing the conversation around menopause and healthy aging.